So obviously, the cancer stem cell hypothesis is based on the fact that there's a subset of cells, let it be small or large, depending probably also on the progression of the tumor, and that have these defining features, which are limited self-renewal, recapitulation of the tumor heterogeneity in terms of generating these more differentiated progenies, and functionally most importantly, as the in vivo tumorigenicity. And there are obviously always limitations to this in terms of translating this into the human system, where you take human cells and put them into immunocompromised mouse. And actually, we do mostly work with these patient-derived xenografts. And based on what Sunil just told you, probably not worth a lot, but I think we have a few aspects that we can still highlight and important to consider. What I'd like to highlight here is actually that there is not the cancer stem cell, rather than this is an evolutionary process, of course. And as the tumor progresses, there are subset of cancer stem cells that also evolve and acquire certain features. And an important one of that is, of course, acquiring the mobility, the invasiveness, and then giving rise to metastases. And I'm highlighting here the circulating cells because that is something we can access very nicely in drawing blood from these patients and isolating these cells, if we can do it in a reasonable way, and actually giving rise to these liver metastases, which is predominant site of metastasis for pancreatic cancer. There's also the route of reseeding. So once these metastases have progressed, obviously you may also find circulating tumors and cancer stem cells in the circulation that actually originate from these metastatic lesions. So what you actually find in the circulation is not necessarily just the primary tumor, rather than whatever recedes in or seeds into the circulation. So with that in mind, what is the cancer stem cell hypothesis or the concept going to add to the therapeutic concept? So I just would like to highlight in a very brief genetic targeting experiments what would actually happen if you target these cells specifically, just envisioning if we had a therapy to target these cells, what would we gain in the clinic? So if you envision that these cells would be evaporated by whatever therapy, one original thought was that you actually kind of kill the root of the cancer and then the whole tumor is going to disappear. That may sound a bit overambitious and probably is not what is actually happening, because obviously the differentiated cells also have a very high proliferative capacity and obviously going to give rise to a progressing tumor and probably will kill the patient. And there's another discussion point, which is actually that the differentiated cells can differentiate and can replenish the cancer stem cell pool, and then obviously the tumor will regress. So if you target the cancer stem cells, not much will happen in terms of outcome for the patient. So what's actually happening in pancreatic cancer, at least with all the caveats and limitations of working in a human system? I would like to introduce you to how we track these cells using a genetic marker. And here, this is NANOC, which is highly expressed in the cancer stem cell subset that can be identified by various means. Here I show you CD133. You can see that there are NANOC positive and negative cells within this subset of CD133 positive cells. So only a subset here is positive, but there is also a subset that is actually CD133 negative and NANOC positive. So we did actually the big effort in transplanting these cells as single cells into mice, and we obviously had to transplant a lot of cells to make sure that we have the bandwidth of detecting tumorigenic capacity, and we have to wait for 6 months. And you can see that none of these cells that don't express any NANOC, irrespective of the CD133 expression, had formed no tumors. If NANOC was positive but CD133 was negative, which is this population here, there was also no tumor formation, indicating that there was no one marker to detect these cells. However, and finally, we were relieved to see some tumors when we actually implanted the double positive cells, and NANOC positive and CD133 positive, which reflects this fairly small population in this particular tumor. But most importantly, what happens when we analyze these tumors, they then recapitulate the heterogeneity in terms of marker expression that we found from or had in the original tumors. So while we injected these cells here that were double positive, at the end, there were lots of cells that actually did not express any of these markers, suggesting that there is a differentiation process. But even more importantly, if we then again transplant these cells, again as single cells, you can see that only this subset here, again, transplants tumors into the secondary host. And this means that this subset is not a subclone in the tumor that is more aggressive and therefore forms tumors, because it can give rise to these all these other subset of cells, rather than that this is a differentiation process where these cells give rise to the more differentiated cells that then lose tumorigenic capacity. So with that in mind, we can conclude that these are tumorigenic cells, and then could do the experiment that if we genetically target these experiments using the nanopromoter to then eliminate the cells and see what happens in vivo. So what we use in just not only using RFP driven by the NANOG1/2 promoter, but also using the thymidine kinase so that we can specifically eliminate these cells by the additional administration of ganciclovir. So what happens here is if you use, so this is all in vitro first, if you administer ganciclovir to adherent cells, which are mostly differentiated and hardly express, I mean, there's no general expression of NANOG here, and there's obviously not much of an effect in terms of short-term proliferation, whereas the in vitro self-renewal capacity is assayed here as sphere formation, where you can see nice sphere formation here in the control. The addition of ganciclovir virtually eliminated all the spheres formed, suggesting that we really target the self-renewal, the cell population that is capable of self-renewing. But more importantly, what happens in vivo? So this is a control, and you can see these are patient-derived xenografts that grow very aggressively and within 2 months actually kill these mice. We selected a tumor or PDX model from a patient that was actually fairly responsive to gemcitabine, as you can see here. So there was an initial response. There was a bit of slowing of the tumor progression, but eventually these tumors relapsed, and importantly here, 2 cycles of gemcitabine until these mice succumb. So this is just the control setting, and you can see here that in the presence of gemcitabine, you see a fairly nice enrichment of these nanopositive cells in line with the preferential killing of the more differentiated and highly proliferated cells. What happens if you administer ganciclovir alone is as shown here, and to our very much of our disappointment, there wasn't much going on here because the tumor was still progressing quite rapidly, whether there was ganciclovir here or there was no treatment whatsoever. And when we analyzed these tumors, we actually did efficiently eliminate these nanopositive cells. As you can see here, there was hardly any tumorigenic capacity left, defined as if you transplant these cells into a secondary host as a challenge. So that leads to the concept that if you target cancer stem cells on their own, you will still have a progressive disease based on the rapid proliferation of all these differentiated cells. However, if we actually combined ganciclovir with gemcitabine, and again, I remind you that this was at least a fairly effective therapy for this particular tumor. There are many tumors and also PDX models that we have that don't respond to gemcitabine at all. But in this particular setting where we had a response to gemcitabine, in the combination with ganciclovir, there was no evidence for relapse up to 210 days. So that and actually was verified, not surprisingly, that there was no tumorigenic capacity left after these days. That leads to the concept that if you have a multimodal targeting, really can result in disease regression and no relapse, but also emphasizes the fact that you need to find a way to combine cancer stem cell targeting with an efficient debulking of the tumor. And obviously, if you want to deliver the treatment efficiently, you also need to target the tumor stroma. I'm not going to talk at all about tumor stroma, but we have shown quite extensively that there's an intensive crosstalk between cancer-associated fibroblasts, as well as, most importantly, the macrophages and the cancer stem cell subset, which is very important for their features. But for the sake of time, I cannot focus on this today. So what we did is to find pathways or targets and to really efficiently eliminate cancer stem cells. So we did a fairly comprehensive transcriptome and epigenetic profiling, focusing on the transcriptome analysis first year for today. And based on bioinformatic analysis and in silico modeling, we came up with a subset of genes that is consistently deregulated in the majority of cancer stem cells, or in the cancer stem cells of the majority of these patients. So in total, we analyzed 25 patients. And then built a tailored RNAi screen. We didn't do a whole genome RNAi screen because that was just simply not possible because of the sparsity of these cells. And data were obviously verified by inducible RNAi and CRISPR-Cas9. So we came up with is kind of a short list that we found to be consistently lost in this RNAi screen across various PDX models, and to some extent is now also being confirmed in the KPC model, and covering different schemes that are or seem to be relevant for cancer stem cells, including the immune system or immune privilege, stemness signaling, of course, and metabolism. We're going to focus on metabolism today for the sake of time. And Sunil already mentioned that there's various metabolic changes or reprogramming going on in cancer. And so far, the data for the cancer stem cell compartment within various tumor entities is still confusing, and probably also very much depending on the model system that you are studying. So we verified all our data in vivo and also in tumors derived from patients. So what we found is that while in the majority of the bulk of the tumor cells, you actually do see enhanced glycolysis as originally proposed from Warburg, where you see mostly the inefficient use of glucose and lactate production. And this is a MYC-driven process. In contrast to that, in the cancer stem cell subset, we actually observe that these cells are characterized by high content of mitochondria, and they're actually strongly dependent on OXPHOS. And they actually have an addiction to OXPHOS because if you target or inhibit oxidative phosphorylation, which you can do not very efficiently, but in a translational fashion using Metformin, but also with other mitochondrial targeting agents, these cells will very rapidly undergo apoptosis. And this way, not just because they run into an energy crisis because of depletion of ATP, but also because they are very much, they have a very delicate balance of mitochondrial ROS levels. So what's essentially happened here, and I'm just showing you some data for Metformin here, is whereas differentiated cells do not respond in terms of induction of apoptosis to Metformin, they do slow down in cell proliferation. But in contrast to that, the cancer stem cell subset here, you see a quite substantial induction of apoptosis. And if you do serial sphere formation assays just in vitro, you can see that there's a subsequent loss of the self-renewal capacity. So there's a particularity in the cancer stem cell population that they are addicted or highly dependent on OXPHOS, and if you even fairly inefficiently inhibit this OXPHOS by targeting complex 1 with Metformin, you see that these cells undergo apoptosis. Obviously, you all know that the Metformin trials in pancreatic cancer didn't go too well. Essentially, there was hardly any effect detectable, and that may be explained or is also recapitulated actually in our PDX models, where we see uniformly, after a short period of tumor slowdown, a rapid progression. And that is actually due to the fact that you don't only have the subset of cancer stem cells that have a high mitochondrial content and thereby are highly dependent on OXPHOS and therefore respond to Metformin, but you also have a variable subset of cells that actually have a low mitochondrial content and actually have a distinct phenotype in a way that they have lower MYC levels. They don't have low MYC levels, but they are lower relative to the other cells, which then actually are metabolically much more plastic and can actually upregulate glycolysis in response to OXPHOS inhibition. And that results in their survival to therapies like Metformin. So whereas these run into energy crisis because they cannot upregulate or activate glycolysis. These cells can readily run on glycolysis and survive metformin therapy. However, we found that if you inhibit the bromodomain or use bromodomain inhibitors to downregulate the levels of MYC, you kind of fixate these cells towards the utilization of OXPHOS, and then they can again become, dependent on or sensitive to metformin. So how that translates? So I mentioned that with metformin we see some, but uniformly these tumors all progress on metformin eventually. Some of them later, and that may be depending on how many of these cancer stem cells they have that are resistant to metformin, but eventually all these tumors relapse. And actually these tumors are characterized by the dominance of these metabolic, much more plastic cancer stem cell subset. So what we see here is during the initial phase or in treatment-naive tumors, so these are circulating cancer stem cells that we profiled them just by the ratio of PGCMA alpha and MYC as an indicator of their metabolic preference. And you can see each of these individual cells. Most of them are actually OXPHOS dependent, and there's a rare subset of cells that seem to prefer glycolysis. If you put them on metformin and then these tumors relapse, apparently, then the majority of these cells actually have switched or are now based on a clone or on clones that are more dependent on glycolysis. So what happens if you inhibit the bromodomain by using JQ1? JQ1 on its own didn't do much in these models. However, if you combine it with metformin, you can see there was nice prevention of relapse as opposed to metformin alone. And if you again look then at the circulating tumor cells, there was actually nothing to detect in these mice, so there was no circulating cancer stem cell left behind. So that is all good. The whole story is a bit longer, and these are all patient-derived xenografts from resected tumors. The responses are not uniformly as promising if you also include patients with advanced pancreatic cancer. But I don't have time to go into all the details. But I can show you some more data regarding the characterization and the isolation process for these circulating pancreatic cancer stem cells. So this is based on the retrieval of these circulating tumor cells from the blood of these patients. And this has been a huge problem for many years for pancreatic cancer, because if you look at the literature and cell search as the FDA-approved platform, you find hardly any cells. So people weren't really encouraged to move forward. And there are now some sorting devices that are based on physical properties. And as you can see, they are more efficient, but we actually found that the highly metastatic cells and the invasive cells are actually go through the system because it's based on these physical properties. So it's actually a filtration system. So you lose a lot of cells using these devices. Cell search is based on EpCAM, and if we use our system just with EpCAM antibodies, this is slightly increased, which just highlights that there's a subset of cells that is not even detected by this system, because this is also an EpCAM-based system. But still, the number of cells is very low. But if we use an approach that is more readily and very specifically actually detects circulating tumor cells using this VAR2 CSA, which is detecting oncofetal chondroitin sulfate on these cells, you can actually get a very high number of cells, and this is all normalized to 7.5 milliliters. But we actually use higher volume of blood, and that's why we can get close to 1,000 CTCs from these patients. And these contain a subset of cells that kind of are characterized or bear the features of cancer stem cells. I only show you some staining here, but we actually have functionally validated that there's a subset of cancer stem cell contained within these CTCs. We can isolate these cells as single cells and then expand them clonally in vitro. We obviously have verified their pancreatic origin by detecting, for example, here the KRAS G12D mutation in this particular patient. You can do the profiling that I just showed you for MYC PDC1 alpha. This is the Metformin transporter, OCT1 to 3. But you can also clonally expand them and then generate secondary cultures from these clonally expanded cells. And most importantly, we have succeeded in 22 seconds. We have succeeded in transplanting these cells into mice and form primary tumors orthotopically. And they are actually embedded in a synthetic niche that we pre-implant and then implant these cells into those, because if you just simply transplant these cells into a mouse, you will not get anything. And these cells or these tumors are actually extremely aggressive, whereas in traditional or classical PDX models, you hardly ever see any liver metastases. Here you will very readily and very rapidly see liver metastases. So these are extremely challenging tumors to treat. As we see a lot of resistance also to our, based on the classical PDX models, developed therapies. So this is obviously what we now testing our models or our therapies in. So these are mostly derived from advanced pancreatic cancer patients because that's the prevailing population of cells that you see in the clinic. And we haven't succeeded to a larger extent in isolating or generating tumor models from circulating cells from patients with local disease. So this is all based on patients with advanced disease. So I don't know what that is. It seems a bit weird. So what we've done, but maybe for the sake of time, I skip over this. So what I just would like to highlight is that the clones that you can generate from the circulating cancer stem cells can be phenotypically very distinct. Whereas here you can see this is a clone that did not express CXCR4, so that was clonally expanded from a single cell. And then these have no metastatic capacity despite the fact that they form primary tumors. And these are actually have EpCAM high cells, but they don't express any CXCR4. Whereas in this different clone here, distinct clone that was also generated from a single cell, you can see that it heavily expresses CXCR4 and no EpCAM in this particular case. And this was a very aggressive clone that formed lots of metastases. So there's a huge heterogeneity within these cells that you can find in the circulation. And so going back to the PGC1 alpha MYC ratio, we investigated whether, so we see a lot of treatment heterogeneity, particularly in these advanced models, and wondered whether we could identify responders versus non-responders based on these circulating cells that then profile for these two genes. And while the responder all had a low MYC level relative to the PGC1 alpha levels, in the non-responders, actually there was a lot of heterogeneity, so it didn't look like we were able to really specifically identify those patients that would respond to this therapy. And that was also true for if we considered the cancer stem cells isolated from the primary tumor. So we thought we were obviously going to miss something by just simply measuring these two genes. But obviously, metabolic profiling of these cells due to their sparsity is very tricky. So we thought we'd just move on and very simply measure treatment response by isolating these cells and then running them through our platform where we can very quickly assess drug response. And these, again, include a synthetic tumor microenvironment being very simple in a way that they contain extracellular matrix, including HA, but also contain cancer-associated fibroblasts and macrophages. So if you then treat these patient-derived cells in this environment, and you can see, just focusing on these combination therapies here, that this was definitely a non-responder in vitro or on this platform, and correspondingly, we also found that this is not this patient was not responding in vivo to this combination therapy, whereas this patient showed very good response on the platform as well as in vivo. And if we just summarize this, we haven't done that for for a massive number of patients so far, but the ones that we did so far, so these were the responders, and they also showed very nice depletion of the cancer stem cell content on this ex vivo platform, whereas the non-responders, which are here in dark blue or Bordeaux, showed no response in vivo, with the limited depletion of the cancer stem cell content in this ex vivo platform, and we kind of defined a 50% threshold. So if we do see a significant reduction of the cancer stem cell content in the ex vivo form of greater than 50%, except for this outlier, we do see good response in vivo. So we'd like to test that, obviously, prospectively now. Oops, sorry. And we'll run that as a co-clinical trial in this Stand Up to Cancer sponsored trial, where we treat these patients with these metabolic targeting agents, and then run a co-clinical trial, which is based on the isolation of these circulating cancer stem cells, which are then screened for the in vivo response, the response on this ex vivo platform, and compare this to the circulating cancer stem cell signature, and then conclude from that whether it's worth prospectively using any of these biomarkers to identify patients that will respond to this therapy. And with that, probably being over time as well, I would like to show you the future vision of this. Hopefully we will have an improved survival, long-term survival of these patients by not actually shifting the curve only to the right, but also shifting it up and having some long-term survivors for this terrible disease. And with that, I thank the team, and thank you for your time.